So, respected President Sir, Dr. Pranam Ranjan, respected Dr. Ajit Babu, our mentor for this program, and respected speaker of today's evening, Dr. Grover Sir, I welcome you all and all the participants to this program of our ORTS, the Ophthalmic Resident Teaching Series. We had the first one last month on Ectropion, and we welcome you, Sir, Dr. Grover Sir, to this program.
Thank you.
With this brief welcome address, now I request our President to say a few words before starting the program.
Good evening, everyone, and thank you, Dr. Sabyasachi, our Chairman, Scientific Committee. And on behalf of EIZOC, I welcome you all to this second part of the webinar. First part we had a few days back. And to take us through this topic, we have the expert in this field, Dr. A.K. Grover, sir, who did the first part also. He is the President of Ocular Trauma Society of India, as well as the President of Oculoplastic Society of South Asia. Today we have Prabhrisha Banerjee, who will be moderating the webinar, along with our panelists, Dr. Shamista Behra, Dr. Suchitra Das, Dr. Malay Verma, Dr. Mihir Mishra, and Dr. Aparna Dwivedi, along with a bunch of enthusiastic discussions. I express my gratitude to Dr. Ajit Babu Manji and Dr. BNR Subudhi for their untiring effort, and also thank Dr. Swaraj Bhattacharya and Dr. Sabyasachi Patnaik for always standing up for the cause of EIZOC. Once again, I welcome you all to this evening's webinar. Let us have a informative scientific evening. So with these words, it's over to you, Dr. Sabyasachi.
Thank you, sir. Thank you very much for your inspiring words. Now I request Professor BNR Subudhi, the coordinator of this ORTS program, to start the proceedings.
Thank you, Dr. Sabyasachi. Let me share the screen. Is it visible?
Yeah.
Visible.
Is it changing also?
It's
Okay.
changing also, sir.
No,
You can
sir,
go to
please
the
make it
slideshow,
full
sir.
screen, sir.
You can go to the slideshow.
Okay. I think it's not coming. And there was one. Is it okay?
Okay,
Yes.
sir.
Okay.
Make it full screen.
Then it's okay. Then there is some problem. It's not coming.
So let's go ahead with this, sir.
No, it's okay.
Yeah, let's go ahead with this, sir, because it's not working, sir.
It's okay now?
Yes, sir. Yes, sir.
Yeah, yes, sir.
Respected President EIZOC, Dr. Pranam Ranjanji, Secretary, Dr. Swaraj Bhattacharya, Chairman Scientific Committee, Dr. Sabyasachi Patnaik, and today's guest speaker, Dr. A.K. Grover, my mentor, Dr. Ajit Babu, and all the panelists and moderators, I welcome you all. And also our President of Odisha State Ophthalmic Society, Dr. Subalkar, to this program today. So I welcome you all. Today's webinar, it's a 20 in the series. And today's webinar is by a speaker, Dr. A.K. Grover. Last time also he was there with us. And he will be speaking on evaluation management Ectropion. So this is the EIZOC team, always with me, mentor, chief coordinator, and today's speaker, Dr. Grover. And I think Prabhrisha will introduce Dr. Grover today, because there are a lot of panelists, lot of posted students. So she will introduce the speaker to them. So Prabhrisha is Associate Consultant Orbit and Optoplasty, Reconstructed Aesthetic Service, AIMS, Kalyani. And today's panelist already told by our President, Dr. Pranam Ranjan, Dr. Sharmista Behra, she is the Professor Bhimsar Burla, Dr. Suchitra Das, Superintendent, MKC Medical College, Brahmapur, Odisha, and also she is the Professor in the Medical College Eye Department. Dr. Malay Verma, currently in practice as an optoplasty specialist in Ranchi, worked as an Associate Consultant Shankaratra, Chennai. Dr. Mihir Mishra is always with us. She is the consultant, MGM Eye Hospital, Raipur. And Dr. Aparna Dwivedi currently works at Dr. Agrawal's Eye Hospital, Bhubaneswar, as a consultant for Orbit Oculoplasty and Aesthetic Services. Our discussions today are really enthusiastic because this time we got more than 6 usual standard postgraduates. So we got 8 postgraduate students from different institutes of our country. Dr. Jyoti Kiranmai from Agrawal's Cuttack, Dr. Dinesh Rao from IGH Rourkela, Dr. Seal from AIMS Patna, Dr. Garima Rath, Dr. Arvind Hospital Pondicherry, and Dr. Raj Kenya from JP Rotary Hospital Cuttack, Dr. Devasis Chanagi, AIMS Bhubaneswar, Dr. Ekagrata Shukla, BHU, and Dr. Nilaksi Banerjee from the AIMS Raebareli. So a lot of enthusiastic postgraduate students will be interacting with our speaker today. They will bombard the questions. I told them to ask questions to the speaker. So with these few words, I welcome once again to all. Now I hand over the mic to our moderator today, Dr. Prabrisha. Briefly, you can introduce Dr. A.K. Grover to the.
Good afternoon, everyone. Thank you for the kind introduction, sir. Although Dr. Grover doesn't need any introduction, everyone knows him very well. However, for the upcoming ophthalmologist, Dr. A.K. Grover is a recipient of the Padma Shri, and currently he is the director of the Vision Eye Center and the ophthalmology unit of the Sri Gangaram Eye Hospital, Delhi. He is the president of the Oculoplasty Society of the South Asia and Ocular Trauma Society. Also, he has been the past president of the AIOS and Asia Pacific Society Oculoplastic Society. So he is also an active member of the ICO, and he has many research papers, many chapters, and he has been a national and international speaker at different conferences. So without further ado, I am handing over to Dr. A.K. Grover, sir, please.
Thank you, Dr. Prabrisha, for those kind words. I'm indeed grateful to EIZOC for making me a part of this wonderful series of postgraduate lectures and postgraduate teaching programs. It is such a wonderful initiative to have these postgraduate orientation lectures and all these teaching programs, and I'm absolutely certain that this series has proven very useful to the entire community of residents and senior residents and fellows in the community of ophthalmologists of the entire country, not just of EIZOC. Thanks to Dr. Pranav Ranjan, Dr. Swaraj, Dr. Sabyasachi, and the entire team of EIZOC. And thank you, Dr. Subudhi, and of course, Dr. Ajit Babu. Thank you very much. So before I am bombarded with any questions, let me start with some questions from the last time. Are any of the postgraduates the same for this time that they were last time, or should I?
I think they've changed. All are changed.
Okay, so no questions then. Then I'll start with my screen sharing and go on to discussion of ectropion.
Right.
I hope my screen is now visible and my
Visible,
sound.
yes. Audible and visible.
Okay. So I'll be speaking on assessment and management of ectropion in the same format as I discussed entropion last time. So we'll first see what the etiology of ectropion is and how do we assess them to arrive at a definite way of classifying them and then considering how best to restore back anatomy and function. So always in all oculoplastic surgery, the principle is to restore back the structure as it should be. And that is what brings the function back. That is what brings the aesthetics back. So ectropion is outturning of eyelid margin, as is quite obvious. And the broad groups are congenital and ectropion. Congenital and acquired. Congenital is a rare entity Rarely it occurs as an isolated entity as well, but you will see very few cases. Unlike congenital entropion, where you do see cases, congenital ectropion isolated is very rare. But as a part of blepharophimosis syndrome, where you have all the other components of blepharophimosis, you also tend to have a lower lid ectropion, especially in the outer part. You can see an attempt at grafting has already been done here. So blepharophimosis syndrome with an obvious ectropion like this is relatively common, and you often do require management when it is severe, like the skin graft done in this case. The acquired ectropion, on the other hand, is much more common, and that is what we are going to discuss. And we're going to see what implications it has on the functioning of the eye and how we can correct that pathology to bring about a return to normal. So the commonest type that we see is the age-related or involutional one, or earlier called senile one. The cicatricial one, where you have a scarring causing shortening of the anterior lamina, would probably be the second commonest. And then we have the entities of changes caused by a facial nerve palsy, or the paralytic one. And then mechanical, any localized pathology on the eyelid leading to mechanical pulling out of the lid. So broadly, congenital or acquired, and acquired can be age-related, cicatricial, paralytic, and mechanical. Let us look at these entities now. Let's go to the age-related ectropion, which you see so often. And what do we look for? How do we diagnose it? So first thing that you notice is that this eyelid is lax and it is turned out. You can see the conjunctival structure here, which you don't normally do. And you can even see a bit of the phonics here. Then the second casualty is the punctum, which needs to be particularly noticed. And it is especially important in milder cases, the so-called ectropion grade 1, where punctum has everted out, resulting in there being a watering. Now, punctal eversion is particularly important because the capillary action that causes the fluid to go through into the lacrimal drainage apparatus no longer functions, and you see a larger lacus of fluid accumulated here. The earliest punctal eversion can be elicited by making the person look up, and it is in that condition that you are able to notice the earliest changes in the punctum. So as I said, you will then have tear pooling, and once the increased pooling occurs, then you start getting an overflow, and secondarily you may start getting changes of maceration of skin and constant dermatitis. Similarly, in the conjunctiva, you have a greater exposure of this part of the conjunctiva. The cornea also doesn't get protected well. Normally, the position is close to the inferior limbus, and then the upper lid is able to close it well and does not allow any corneal exposure to take place. But with the lid retracted like this, the upper lid will also not be able to do the job completely, and you can start getting a stippling or punctate staining with fluorescence of the lower cornea. So a corneal exposure can occur. And similarly, secondary conjunctival changes often start taking place, leading to keratinization at times, leading to change in color values, and at times you even start getting a closure of the punctum as a result of persistent exposure. So these changes are important to assess. And when you see these changes, which are age-related, patient who's elderly, you can easily diagnose when there is a complex association of all these entities. You can easily diagnose a age-related or involutional. Now, one important thing to assess is punctal eversion. Now, if you hold the lid, pull it, you can see that the lid can be displaced from the grid. If this is more than 6 to 8 millimeters, it indicates laxity, as you can see here. If you are able to pull it abnormally high, like 6 millimeters or more, you even have grading systems which are less important to understand than the concept. So snap back is a good test. You pull the lid and you put it back. If it falls back immediately within a few seconds, you know it is a normal inversion. But if it doesn't, if it goes back slowly, you know that there is a slow recovery, indicating an eyelid laxity. Now, let's see how you further subclassify this. You also particularly want to see whether the laxity is much larger on the medial canthus or it is much larger on the lateral canthus. So when you pull the medial eyelid and you find that the inferior punctum has gone well beyond the nasal limbus, then you know there is a medial canthal tendon laxity. And unless you address that and just do a shortening of the eyelid, this will not work. So a medial canthal tendon laxity is important to assess. Similarly, a lateral canthal tendon laxity is also important to assess. So when you pull this lid, you again find that the lateral canthus is being pulled towards the lateral limbus. Also, you also notice a rounding up of the lateral canthus. Instead of the normal acute angulation that you have at the lateral canthus, you find that there is a rounding up because the attachments to the lateral bony rim have become weaker. And thereby you get a lateral canthal tendon laxity. So let's once more recall what all we have assessed. So age-related ectropion, we've seen there is a laxity and eversion. There is a punctal lack of apposition, tear pooling overflow, conjunctival corneal signs of exposure. You have seen that there is a pinch test showing a laxity of more than 6 to 8 millimeter. You've seen that there is a slow recovery on snapback test. And you've seen that there may be an associated predominant medial laxity, predominant lateral laxity, and then MCT laxity and lateral canthal tendon laxity. So these are the things that we have looked for in involutional or age-related ectropy. So once we have done that, then is the best time to decide what to do for management. So if there is a medial ectropion and there's just punctal eversion, you may be able to rotate it back simply by removal of a conjunctival spindle. We call it Jones conjunctivoplasty, and we look at this procedure. If there is punctal eversion on the medial side, along with laxity, then you have to address both. So you have to do a medial canthal procedure, which we'll see one of the procedures can be this, or you do a procedure called lazy T procedure, which is a combination of a conjunctivoplasty with a pentagonal excision in order to take care of the eversion and laxity. But when you have a medial ectropion with medial canthal tendon being particularly at fault, then you need to combine it with tightening of the medial canthal tendon. So either just rotation of punctum or shortening or MCT tightening, depending on if the laxity is significant. So let's look at these procedures. So for punctal eversion, you may just do a Jones conjunctivoplasty, also called conjunctival spindle excision or diamond-shaped excision. So see this spindle that has been drawn in the lower lid. Now we'll see what the principle of creating this is. This must be in line with the punctum if it is to cause an inversion. So you have to remove this spindle and then do a tightening suture. So this essentially is the principle, but let's look at it in the video. Now, this is a lazy T procedure where a conjunctivoplasty is being combined with a punctal, combined with a lid shortening. So now you see this is about an 8 millimeter spindle which we have drawn directly behind the punctum. This is about 8 millimeters, but it must be at least 5 millimeters behind the punctum in order not to injure the canaliculus. You can also put a probe at this stage and this time. Now we are assessing how much the laxity is, how much of the excision that needs to be done. So we have defined the, done the marking, and we are excising the conjunctival spindle. We also excise some additional tissue in order to cause more inversion and more scarring and cautery of the edges. When we cauterize, you cause more scarring because you want an invert scarring to take place. Now we are doing a pentagonal excision. This excision is with the principles that the vertical borders should be parallel to each other and right up to where the tarsus ends, the vertical limbs, and then the two are joined together to create a pentagon. So this pentagon has been created. Now, why is it called a lazy T procedure? When you close this, it will become a line like this, and the conjunctivoplasty is like this. So what does it become? A T, which is lying down. A line here and a line here once you close this. So this is lying down, so it is a lazy T. And then when we did the suturing, we also ensured that we took a bite through the lower lid retractors, tightening it further. And that is why we close the conjunctiva first before we are closing now the marginal defect that we have created by pentagon excision. And we already discussed how to do a marginal repair. So this is a vertical mattress suture that has been placed. The first bites being 3 millimeters from the cut edge, going to the other side, coming back 1 millimeter from the cut edge, 1 millimeter depth, and coming back to the original side. Now, the first suture was just behind the gray line through firm tarsus. Second suture is passed closer to the posterior margin. We want a thorough closure so that the marginal, the function of the margin for capillarity will function well. And a third similar suture is passed close to the lash line to get a very good closure. So now we have a vertical line here and a line of closure of the conjunctivoplasty here. So this becomes a lazy T procedure. So what has lazy T procedure corrected? It has corrected the outward turning of the punctum by causing inversion with that spindle-shaped excision and suturing, including tightening the retractors, causing more fibrosis by cauterization, and shorten the lid by excising a pentagon, which is always the principle when we shorten the lid, and by doing a good marginal repair. So when there is a medial ectropion, what do you want to do? You want to tighten the medial area. So what do? You make sure that before you do any procedure, you ensure that you have a probe in the punctum and you will not damage that. Raw the areas on two sides and then tighten it by joining these two. This will tighten the medial canthus and you will get a good closure as you see here. Now, this can be combined where medial canthal tendon laxity is present by medial canthal tightening, and we will see that procedure. So after tightening, we have done a good tightening of the medial canthal area by doing a medial canthorrhaphy, but ensuring that you don't cause any damage to the punctum or the canaliculi. So if you have a medial canthal tendon laxity like you see here, then MCT plication needs to be carried out. Now, there are two ways. One is that we just plicate and tighten the medial canthal tendon here locally by shortening it and passing mattress sutures from here with either a vicryl, or sometimes we prefer a more permanent suture, and attaching it to more medial part of the anterior crus, or you can even expose the region of the anterior lacrimal crest and tighten it there. But a better procedure is if you are able to tighten it to the posterior lacrimal crest. which is behind the sac. So let's look at that principle. So if you cut the conjunctiva in the region of the precaruncular area, pass your scissors medially but backwards directed to go behind the sac, then you end up at the posterior lacrimal crest. And if you expose that with the dissection with your scissors, keep the fat away, then you can tighten the medial canthal tendon to posterior lacrimal crest, which will give a really good direction. So this is the area of the posterior lacrimal crest exposed. You can pass a Prolene suture through that, as we have done here, and then take a bite through the medial canthal tendon here. And when you tighten this, you will get a very good posterior direction of the medial canthus and a very good tightening. So a medial canthal tightening like this can be achieved, which will give a much nicer result. So a laxity like this will be addressed, and then you at the same time need to do a lateral canthal tightening. But if you just did a lateral canthal tightening without medial canthal tendon laxity being addressed, if it is present, then you would get a pulling out of the entire medial canthus. So this is the example of that lady, generalized laxity. So we have done a medial canthal tendon tightening as well as a lateral tarsal strip. You can see the lateral tarsal strip is well tightened and the medial canthal tendon has not been displaced because we've been able to do a good MCT plication as well. And now all this laxity is gone and it is well opposed, so capillary action can function. But medial ectropion is just one part of it, but there may be lateral ectropion or generalized ectropion. Most of the time, other procedures have now been avoided, the ones that we will talk about, Kuntz-Zaimanowski classical. We do the lateral ectropion correction by lateral tarsal strip procedure, or a new variant called lateral canthopexy. So let's look at the lateral tarsal strip procedure. We saw it briefly last time as well. So a lateral canthotomy is first done. Expose the lateral orbital rim. Next, we give an incision at the gray line, depending on how much is the tightening that we require. Then give an incision below the tarsal plate in order to create this lateral tarsal strip. Remove the mucosal lining because we're going to bury this part and we don't want epithelium to get buried and creates this. Remove all the epithelium from the surface. You're just left with the tarsus now. And then this strip can be tightened by reattaching it. The excess skin is removed in that area, skin along with lashes. Now we're taking a bite with a double arm suture from the posterior to anterior and then attaching the suture from the anterior surface onto lateral orbital rim just above the Wittnall's tubercle at the lateral rim. But this bite, as you can see, starts behind the rim in periorbita and comes out in front of the lateral orbital rim at the periosteum. So this is a double arm suture which has taken very good firm bites. You can feel the tension when you take those bites. And when you tighten it, you will get a very good lateral canthal tightening. We're using a Prolene suture here and we've done that tightening. And then we recreate the margin by taking a vertical mattress suture as we showed earlier for marginal repair. First bite 3 millimeter away and second bites on the return 1 millimeter from the cut edge and 1 millimeter depth in order to get a good apposition of the lateral canthus. So we oppose back the lateral canthus, making sure we recreate the lateral angulation. The lateral acute angulation. Normally the lateral canthus should have a tight acute angulation. We restore that and then we do a skin closure in the region of the lateral canthotomy. Hope the procedure is clear. So essentially what we have accomplished is removing the excess lid from here, retaining the tarsus without epithelium, and anchoring it somewhat higher and at the lateral tubercle with double arm sutures, making sure we start behind the orbital rim in periorbita. Now, this is a very good procedure. And as I said, this is the number one choice for lid shortening now rather than a pentagonal excision, which disturbs the margin in some way. But it is also not totally without disadvantages. There can be recurrences or exacerbation of the problem at times. Lateral canthal angle is being disturbed. Sometimes you may cause other complications, rare complications as well. So there is another procedure which is commonly followed for milder cases called lateral canthopexy. Here, we are not excising any part, not opening up the lateral canthus, just carrying out a tightening by fixating lateral canthal tendon to the lateral orbital wall in an elevated position without resection of the components of the eyelid or canthus. So you're essentially avoiding a canthotomy, avoiding any disturbance of the canthus, just reattaching. So what do? So we create a raw area here, or now this is the lateral canthus which is lax. So we create a raw area at the margin, take a double arm suture, pass one limb through this part, one limb through this part, then change the direction of the needle, go and take a bite similarly through the periorbita and periosteum, and give an incision here in the upper lid, emerge through that. So we've taken a suture from here, created a raw area, double arm suture, direction change, bite taken through periorbita and periosteum, and emerge through a skin incision given in this area, and tighten it under the incision. And the small lid incision will close by itself, or you can give a single suture. So instead of doing a canthotomy and cantholysis and all those incisions, you're just attaching this part. There will be a little distortion that will appear initially, but that will go away. So you're just taking a tightening suture, double arm suture here, taking a bite through periosteum, periorbita, and emerge at some incision given here and tighten it there. So that achieves a good tightening without disturbing the lateral canthus. But this will work for milder cases. You can use a orovicral suture or even a proline suture. Now, just as we talked about everting sutures for Ectropion, we have inverting sutures also, which can be used along with other procedures or sometimes as a temporizing procedure in very sick patients. Now, what was the principle in everting suture? Can any of the postgraduates reply now? Ajit ji, बताइए कौन रेजिडेंट जवाब देगा? इन everting sutures कैसे थे, उसका किस डायरेक्शन में पास होते थे, क्या प्रिंसिपल था? बताओ, किससे बात करेंगे? Dr. Ajit Babu, you are silenced. Muted.
Jyoti Kiranmai. Sheel, Dr. Sheel.
Yes, sir.
Were you in the
Kiranmai, Jyoti is there. Yeah.
Dr. Jyoti, can you tell us what was the principle of everting sutures used in Ectropion correction?
In Ectropion correction, we will do the horizontal lid laxity will be corrected, sir.
No, there is a suture which can correct it temporarily.
Quicker
Yeah, suture. So what is the principle of the quicker suture? How do you pass it? What is the direction?
In quicker suture, there will be transverse everting sutures with transverse lid split.
Okay, one is a transverse suture, which also works, but doesn't work as much as the everting suture. So there the principle was that you pass the suture from the area of the fornix went between the two laminae and emerged anteriorly, close to the margin. Now, this is the margin. So, if you pass a suture in this direction, on the conjunctival aspect, deeper, on the skin aspect, closer to the margin, then it will work as a everting suture for correction of entropion. Whereas for correction of ectropion, if you want to invert, then you have to pass the suture closer to the tarsus and emerge further away from the margin. So this is the principle of inverting suture. So we'll see this principle used in some of the subsequent procedures that we'll talk about. So Jyoti, can you explain what we have said so far? What are the assessments, broad assessments that you do? Just tell me 5 important points that you assess in a ectropion patient, age-related or involutional. Dr. Jyoti.
In involutional or
Ectropion.
involutional ectropion, we will do pinch test, sir.
Okay. What are we checking by pinch test?
In pinch test, we will check for the distance between the edge of the globe and the eyelid margins.
So what pathology is it telling you about?
It pinch test will tell about the lid laxity, sir.
Correct. So you're knowing about lid laxity. What else do you assess?
Snapback test we will do, sir.
Okay, that will also tell you about the laxity and length.
It will also tells us about the lid laxity, sir.
Okay, what else?
And to see the canthal tendon laxity, we will do the lateral canthal tendon laxity and medial canthal tendon laxity. Sir.
That is important because we want to assess what kind of laxity is associated with the canthal laxity. What else?
Orbicularis muscle tone also we will check, sir.
Okay, so predominantly
we will check for tearing.
Whether it is a medial ectropion, lateral ectropion, or generalized ectropion, right? And then you also need to see how much the laxity is. You also want to see whether there is a specific medial canthal tendon or a lateral canthal tendon laxity. Okay, so this is essentially what we have determined so far. So we spoke about medial ectropion and how to correct it. We spoke about lateral ectropion and we are now going to talk about generalized ectropion. So generalized ectropion, also sometimes called tarsal ectropion when it is severe, where the entire tarsal plate is turned out. So this indicates a generalized laxity, generalized lengthening, eversion, and what you call a grade 4 ectropion. But more important than grades is always to understand the severity. So this is what is called a tarsal ectropion. Now, what do you do in tarsal ectropion or a grade 4 ectropion? So here we have already spoken about tightening on the lateral side, a lateral tarsal strip procedure. We've also spoken about how we pass the inverting sutures. So inverting sutures will be passed and lateral tightening will be done as a combined procedure, and you may sometimes combine it with an excision of a spindle of conjunctiva throughout the length from the inside. So if you do a combined procedure like this, an inverting suture we've already said is passed from just under the tarsus here and emerges closer to the fornix. So we passed these 3 sutures which are emerging close to the fornix. These are 3 such sutures along the entire length, along with lateral tarsal strip, and the combination of the 2 is correcting the tarsal ectropion. You can see now that post-operatively it has been markedly improved from this position. Now let's look at the generalized ones being either moderate or moderate to severe. If it is just a mild one or moderate one, you can just do a lateral tarsal strip procedure. But if it is moderate to severe, then you need to combine would do a combined procedure like the one that we have just seen, or you should know this procedure, which was the traditional procedure but is no longer done very often, is a Smith's modification of Kunt-Zymanowski. If I take this slide off, how many of you can spell Kunt-Zymanowski? This used to be a favorite question of some examiners, traditional examiners. So you should know this spelling, Kunt-Zymanowski's procedure, Smith's modification. I'm not going into the details because it's not a commonly used procedure now. So are the procedures for medial ectropion, lateral ectropion, and generalized ectropion clear now? So we need, Dr. Ajit Babu, you need to identify the next resident who will reply to that.
Dr. Garima Rath.
Garima will answer.
Dr. Garima, are you there?
Seal, Dr. Seal, are you there?
Dr. Sheel?
Yes, sir.
So Dr.
Yeah,
Sheel,
Dr.
you are
Sheel.
going to tell me what were the procedures for medial ectropion, what is the procedure for lateral ectropion, and what are the procedures for generalized ectropion. This is all about age-related or involutional ectropion.
Yes, sir. In case of medial ectropion, we will look where the ectropion is. Is it at the level of the punctum? If there is only punctal eversion, then we can do Jones conjunctivoplasty.
Right.
If it is along with lid laxity, we can do the lazy T procedure.
Absolutely.
In
right.
which is a combination of conjunctivoplasty and pentagon excision.
Correct.
And if it is with a medial canthal tendon laxity, we can do medial canthal tendon plication.
Correct. Absolutely right.
In which it is better to plicate it to the posterior lacrimal crest than the anterior one.
Perfect.
In case of if there is lateral ectropion, then we can do a lateral tarsal strip procedure.
Okay.
In which we dissect out the lateral tarsal strip and then we suture it to the lateral periorbita or periosteum.
Correct.
And
for the milder cases, any option?
Sir, lateral canthopexy can be done. In this, just an elevating suture is passed.
Correct. Perfect. Okay. And for the generalized ones?
For the generalized ones,
moderate and moderate to severe.
In the moderate one, we can give lateral tarsal strip with inverting sutures.
Okay.
And the one which is obsolete, the Cohen-Zamanovsky procedure for severe one. Or the combined.
Okay. So that was perfect.
Excellent.
Very well recalled.
Yeah.
Thank you. So now we go on to the entity of cicatricial ectropion. So we discussed the principle last time of how an entropion or an ectropion takes place because of cicatrization. And we recalled the experiment in your physics with the iron on one side, copper on the other side. So with cooling, when there was because of differential specific gravity, one would expand or contract more, it would shift the plates in this direction. Like so, if the inner plate is to contract more, then you will get if the inner plate contracts, then you will get a turning of the margin like this. If the other lamina contracts, if this is the outer lamina, if this contracts, then the margin will shift out. So this is the ectropion, this is the cicatricial entropion. So let's look at this cicatricial entropion once the principle is clear. So if you get a chemical burn like this, then you will often have margin turning out because there has been an excessive scarring in the outer part. So shortening of anterior lamina can occur due to a number of causes. Trauma is a very important one. Burns, either chemical or thermal, are another important cause. So this is another reason. And then infective lesions in the skin are often a cause for cicatricial ectropion. But chemical injuries remain one of the more common causes. The examples that follow, we will see different types. So the most critical assessment is whether there is a localized contraction which has taken place, or whether it is a diffuse or a generalized contraction of skin that has taken place. And accordingly, we do the correction. But one important principle is that you would like to wait for a period of time, say generally 6 months after a trauma, for the scar to become matured, which implies that if you do another trauma of surgical trauma on that, you would not cause a reactivation of fibrocytic activity and a reactivation of an entire process of inflammation and cycle of fibrosis to cause a recurrence of the problem. So that is why if the ectropion is not causing a compromise of the cornea immediately, then you try and defer it till you do a secondary repair or a late repair at 6 months of since the trauma. Now, let's see if there is a localized shortening causing a localized ectropion, what do you do? So one important principle is that in localized, you may not necessarily need replacement of like by grafting, but you can mobilize tissues from sides by Z-plasty or VY-plasty or X-plasty or one of those procedures which utilizes the surrounding things. Surrounding tissue, excess tissue from another direction and uses them up. So let's look at this principle. And then we'll see in generalized, we need either replacement or use of by either use of flaps. I'm not going to repeat flaps today because we can discuss that separately, and we'll talk about grafting for getting the tissues back. So let's look at Z-plasty and VY-plasty. What is the principle in Z-plasty? If you have a shortening occurring like this, supposing this is a margin, and this is the line of shortening causing a localized ectropion like this, and this is the line of shortening, then the central limb of Z is in the line of direction of shortening. Two other limbs are made at an angle of 60 degrees approximately from this, and then you undermine this. You free this flap from all the underlying tissue. So it comes to lie like this. And then you free this from all the underlying tissue so that this becomes free as a flap. This becomes free as a flap. Then you lift this and put this apex here. You take this apex and you put this apex here. So what will happen? This particular shortening or this A and B point will become lengthened to this distance, which is, let's say if this is C and this is D, then AB will become as long as C and D because the flaps have transposed. As you see, this apex has come here, this apex has come here, and this apex has come here. So in effect, this tissue has been mobilized, this has become shorter, this has become longer, and this has become shorter. So this tissue has been utilized to elongate this axis. So after this closure, you have accomplished this. So we'll see this in the animation, which Dr. Aman will show you shortly. Let's look at VY-plasty also. And then we can talk about see the animations like we saw last time. So in VY-plasty, if it is a shortening which has taken place in a zone like this, if this is the eyelid margin, and there has been a scarring here in this zone, if you give a V incision and the margin is being pulled like this because there is an ectropion like this. Now this V, if we give an incision and separate it from the bed, undermining from the bed, this will come to lie like this because it is shorter than the bed. And then this area will be left raw. So we mobilize the tissue from here, mobilize the tissue from here and close it like this. So close it like Y. So what it has done is utilize tissues from the sides in order to give lengthening in this direction. So this is VY plasty. Hope this is clear. Let's look at animations. I'll stop sharing, Aman.
Yes, sir. I'll share my screen.
Hello. So Aman will share his screen. It doesn't play on Mac laptops. It only plays on the other laptop. So Aman will share his screen and show us the two plastics.
Is my screen visible, sir?
Yes. Please go ahead. So see the ectropion in this direction. And then when the flaps are mobilized, this ectropion has corrected because this has become, AB has become equal to C and D. See this ectropion being corrected? So this is what happens. Once again, let's play it. Shortening in this direction, central limb of Z, this is at 60 degrees, this is at 60 degrees. The two flaps mobilized, this is corrected. Okay, go ahead and show us VY plasty.
Just a second, sir.
So is Z plasty clear to everyone?
Yeah.
Okay.
Very clear.
Now this is the V that we were speaking about. So we have undermined it. So it has come to like this. This area has become raw. Mobilize this, closed as Y. V up to this point, undermined, it has come to lie here, raw area here, mobilized from here, and closed as Y. So we'll see a video also. Once we have seen the video of a VY plasty, it will become even more clear, and some pictures of some cases. Thank you, Aman. That was very useful.
Thank you, sir.
Is VY plasty clear, everyone?
Yeah.
Okay.
Clear.
Thank you. It should not be clear to you, it should be clear to the residents.
No, I will also practice if it is clear.
Then I'll start practicing retina.
Please.
Okay, so VY plasty and Z plasty we've seen. So let's see a clinical example. You see there has been a cicatrization, and you can see an area where the eyelid is lifted here and an area where eyelid is lifted here and distorted also. This is because of the cicatrization here. So since this is a localized change, we decided that this was the area or line of shortening. We marked a Z here and utilized tissue from around. When we closed this Z after mobilization, you can see the change in that direction now. Now this has become corrected. So how does an umpire decide that there is a gap between the bat and pad and the bat and the ground, and there is a shadow in between? So you can see there was a shadow here, and bat is not grounded. Now after this, the bat is grounded. Now there's no shadow, right? So he's not run out. So similarly, for a VY plasty here, there was a shortening in this direction. So given a V, and once we undermined, it came like this, mobilized tissue from here, closed it like Y, and this ectropion has also been corrected. So if it is a localized problem like this, you can see the gap here, which has now been corrected. So if it is a localized problem, you can use a mobilization like this. So let's see an example of VY plasty. You can see the gross ectropion here because of cicatrization. Since it is in one line, we decided to do a VY plasty. Now we are doing an undermining of this, removing the scar tissue from the bed, and you will notice that by doing that right up to the margin, we will correct the ectropion. Removing the scar tissue from the bed, and you can see the margin has become so much better after this becomes lax. Now we don't have the same ectropion, and we have to mobilize from both sides because that is where the closure of V to Y will occur. See this now?
Yes,
Once
yes.
we mobilize from side and close it as Y, the ectropion is corrected here. So VY plasty has corrected our ectropion here. You can see that, right? So that is the principle. Okay, when it is generalized, then one option, of course, is skin grafting, but you can also use flaps where possible. In a situation like this, of course, flaps are not possible because there is scarring everywhere. But if there are healthy tissues around, you can use them for flaps also. Flaps essentially are skin with intact vascular supply from an adjacent area
Medical.
to the other. One is pedicle flaps. You have various types of flaps. You have the sliding flaps, you have the rotation flaps, you have the rotation flaps, then you have pedicle flaps, then you have interpolation flaps. So all those can be used from surrounding areas. You have so-called trippier flaps, or flap from the forehead region. So all those flaps can be used. And who's the father of flaps? Not Ajit Babu, Sushruta. Sushruta was the first one who did it for deformed nose. So
Yes.
nose was repaired by using flaps by him. So Sushrut takes the credit. So for generalized, you need to replace like by either full thickness skin grafts or epidermal skin or partial thickness grafts. So let's look at the example. So full thickness grafts are indicated particularly for the thicker skin of lower lid. Lower lid skin is thicker than the upper lid skin. Upper lid skin needs to be much softer, supple, and to allow the blinking and all the mobility of the upper lid. But lower lid skin is thicker, so lower lid full thickness is preferable. And it can only be done in a healthy bed. Why? Because full thickness graft is thicker. It needs a richer blood supply in the bed. If the bed is unhealthy, it will not be able to recirculate the graft. Whereas partial thickness graft is more hardy, it will grow even on a bone. So full thickness graft, even though it is full thickness, it still shows some contraction. So you need to take a little extra, about quarter extra, in order to compensate for the contraction that is going to take place. You carry out an apposition by edge-to-edge suturing. We'll see this in the video. And graft is then apposed to bed with tied over cotton pledget, or what is called quilt sutures. Sutures which go through the skin and which go through the bed in order to keep the graft apposed to bed with tied over suture, cotton pledget, or some other bolster which keeps it attached, because there is a process of transudation that takes place in the bed from the raw area. If it lifts the graft away, it will not get its blood supply. So it has to be kept opposed to the bed. And this apposition is done by either putting a pressure on it or by taking sutures through the bed. So this is the principle in full thickness graft. So this is an example of cicatricial ectropion like this, where there is it's much larger than a localized one, which cannot be corrected by a simple plasty. So we need to put in a graft. So we give an incision, a subciliary incision, as you see here. We see how much the defect that is created. We take a corresponding graft. Here we're taking it from the post-auricular area. This is the pinna. Part of it is on the pinna. Part of it is on the skin from before the hair-bearing part starts, because you don't want to graft the hair-bearing part. Then after you've seen what the area of the defect size is, about 25% extra. Make the graft thin by stretching it between your fingers and using a scissors, because the lesser the thickness of the graft, the easier it is for it to take back that supply. And then you put it back and you use double arm sutures to close the area of the pinna. You put the graft in here, suture it well, tied over bolster to make sure that it does not lift from the bed. Cotton pledget here, long sutures left on either side, which will tie it down to the bed and ensure that it doesn't lift up. You remove it after a week or 10 days, by which time the graft has taken up. And post-operatively, you are able to correct the ectropion by this graft. So let's see the video. So this gentleman has an ectropion of the upper leg. So we decide that we have enough skin on the opposite side. So we mark the lid crease on the opposite side as well. And here we are giving an incision in the lid crease line. And we are removing, you can see the resistance that we are facing, because there's a lot of scar tissue in the bed. And all that feels firm as the scar tissue, we will excise. Undermining on the sides, under the scar, make sure that you fully release the lid from the scar. Only then the ectropion will get corrected. So we measure the size of the defect. We do a free blepharoplasty on the other side to take the skin. So we are taking this excess skin from the other side, because this is an elderly gentleman, and you get the benefit of a improved lid crease and blepharoplasty on the other side. Take a thin graft. Close back the other eyelid. Put the graft here. 25% excess. And as we put the sutures, we ensure that we keep dividing the excess well. Once this graft is done, now we are dividing the upper scar by multiple Z-plasties, but we'll skip that. Now what we're going to do is put a pledget here, all the long sutures left, we tie this together in the bed, put an antibiotic here, and this is what happens. Our ectropion is corrected now. I can close well now in all directions, and it looks much better. This scar has also been improved significantly by dividing into multiple small Z-plasties. An example of a girl who had a couple of lacrimal surgeries done somewhere and came back with a severe ectropion. Her epiphora would not correct. So we had to put in a skin graft, and the skin graft corrected the ectropion. This is the skin graft. This is the ectropion that she has because of the scarring here. And this is after the graft. So we've spoken about the full thickness grafts and what are the areas from where you take it. We already spoke about the post-auricular, but you can also take it from supraclavicular or preputial skin, or depending on how much thickness you want, how supple you want it, and so on and so forth. So those are the common areas for full thickness skin graft. Now the epidermal is as we know, a partial thickness graft. We are taking just the epidermis. It is indicated in upper lid where the lid is thin, supple, allowing binking. When there is a large area that needs to be covered, multiple lid involvement, because you can't take that big a full thickness graft and then you'll have a problem on how to cover that area. Then in unhealthy situations, supposing you've had a recent burn and you have to put in a graft. So a graft with unhealthy bed will not take up a full thickness graft, but a epidermal graft will. And in burns, since the skin around is a little lighter, the partial thickness skin gives a better color match also. And then, of course, you know that you use partial thickness grafts in a place like exentration socket, where you have to put it just over a raw bone. It will not take up, full thickness skin will not take up. But here the contraction is a little more. So you need a 30 to 40% extra size. And you put sutures which are overlapping the graft edges. You don't, that means you don't do an edge-to-edge suturing. You leave an extra skin around the, supposing defect is this size, you leave a little, take an epidermal skin which is this size and put a suture through this raw edge to the a part of the epidermal skin, which is not the edge, short of the edge. So there will be a little skin overhanging on all sides when you do the suture. We'll see that in the later pictures. And then because this is much thinner, it's much easier for it to lift off. So you also give multiple stab incisions in it for drainage so that it will not lift off from the bed. And then you can, of course, tie it over with cotton bolster or pledget as you see. So this gentleman came after a chemical injury. He had already lost this eye and he had a severe ectropion like this. So this is on 11th March, and by 13th March, it had become so much worse in 2 days. You can see that this is totally ectropic now. This is already developing a dryness, and this eye, the only remaining eye, is severely threatened. So this is a Humvee's knife which we are using on the side of the arm to lift off the graft. You have to learn to do it, use it to get the kind of thickness that you want. And this raw area heals by itself. You do a dressing by using a fairly gauze, which is medicated and which is lubricated with an ointment. You use the Humvee knife, take this graft, put this graft in bed, and you see how we are placing the suture. This suture bed was like this, as you see here. We're taking a bite through this edge and taking a bite through the graft, not through the edge, but with a little overlap on all sides. And you can also see that we have made some stab incisions within this to allow the bed to drain. And this is a antiseptic soaked swab which has been put in, tied so that it takes up. And over a period of time, say 5 weeks later, the skin has started taking up. By 4 months, it has taken up. And you can see it has a light color than full thickness graft, and it has matched the light skin all around. And by 4 months, it is taken up well, lid crease is formed again, and eye is closing well. So pre-op, post-op, cornea looks healthy now, and eyes is safe. So summary of management: localized ones, you can mobilize the tissue from around; generalized, grafts or flaps. We've not particularly mentioned it here because often the situation is like this, where around surrounding flaps are difficult to take. But if it is a possibility, then use a flap, because flap is with intact vascular supply and takes up well. So now the other two entities are easier, much less effort left for us. But paralytic, I hope, is now clear. The concept is clear. I don't think there are too many points here, so we don't need to repeat. Any postgraduate would like to have any questions on cicatricial ectropion or summarize this for me? Who will summarize it?
Ekagrata Shukla. Ekagrata Shukla, are you there? Dr. Nilakshi? Otherwise, we need to go to Dinesh Rao.
Yes, sir.
Dinesh Rao? Yes, he's there. Dinesh Rao.
Will you summarize the management of?
Yes, we are, for localized, we do Z-plasty and VY-plasty. In Z-plasty, we make 2 flaps at an angle of 60 degrees, and we make it, we lengthen the lamina of the anterior anterior lamina. And for VY-plasty, we make a V incision and we make it into a Y-shaped incision, Y-shaped thing. And for generalized, we use flaps and partial thickness and full thickness graft. For partial thickness, we use we take epidermal thickness graft, partial thickness graft. For full thickness, we take the full thickness graft, and in case of
Okay.
in case
Full
of
thickness,
partial
how much
thickness
extra
graft,
size will you take, Dinesh?
full
Full
thickness,
thickness? Yeah.
we don't take we take more extra
Extra
for
size, how much percentage will you take?
20% extra size we'll take, sir. For
20 to
partial,
40.
we take 30 to 40%.
Yes.
In partial thickness, we overhang the edges, whereas in full thickness, we don't overhang.
Yeah, edge to edge suturing.
Yes. And what knife will you use for partial thickness graft?
We use Hermpy knife, sir.
Okay. Great. Thank
Good.
you. So let's go on to paralytic ectropion. So many of the principles of involutional ectropion will apply here. And you have the same features. If there has been a facial nerve palsy, as you see here, there is an increased size of the palpebral fissure. There is a laxity of the lower lid, laxity of the upper lid. There often occurs a lengthening. There is epiphora, and there is lag of thalamus, inability to close the eye. So all these features you need to evaluate: amount of laxity, amount of lengthening that has taken place, severity of epiphora, size of palpebral aperture, extent of inability to close or lag of thalamus. So once you have evaluated these, then you tackle it just as you would do in involutional ectropion, though severity may be more and you may need some additional procedures. So laxity is tackled as we did in involutional ectropion, but often needs to be combined with tightening of medial canthus and lateral canthus. Fascia lata sling procedure is another procedure that is used for lower lid for laxity, and temporalis muscle transfer was particularly used in cases of paralytic ectropion due to leprosy, which was very common. So that procedure was, you need to know, for much more for historical reasons, where there used to be a huge burden of leprosy patients where we needed to bring in temporalis muscle for support of the lower lid. For lag of thalamus and upper eyelid retraction, there are a number of other procedures. Like, for example, the commonest now used is either gold or platinum weight, which is added. Now, you see this piece of gold. The exact weight that is required is determined. It is tied partially over the tarsal plate and partially higher to it. It has holes which are used to fixate it to the tarsal plate, and then it provides a better closure. Of course, you know of various dynamic things like springs that can be used, but these are all procedures which are no longer much in use. So there used to be springs to keep the eye closed, which were used, or there were various other devices in order to get a dynamic closure of the other lid, but they are all relatively redundant. So you use these implants and then you close the eye. Gold weight measurement, we'll see how it is done. Then if there was a lid retraction element, then you have number of procedures for correction of lid ectropion, like excision of the Miller's muscle or lengthening of the upper lid by putting in some kind of a spacer graft, or a full thickness lid split procedure. So there are a number of procedures which are used for lid retraction if the palpebral fissure size is more. And there was temporalis muscle transfer techniques. Now, what was done in temporalis muscle? You gave an incision in the region of the temporalis fossa, you mobilized a part of the muscle to create a strip, which was then taken from to support the lower lid from the outer part to the inner part. Here it was anchored to the medial canthal tendon. This is the illustration of the flap that was created. So about a 10 millimeter wide strip used to be taken and which is transposed to support the lower lid and canthal tendon. Okay, now let's look at the procedure of gold weight implant. We first need to see what is the right size of the implant. So this is a thin strip of our tape that we have used, and this is a silver trial weight which I have, which you first put on the lid. This palpebral fissure is larger, and you know the lag of thalamus. You put it with a tape and see which is the weight that is causing the eyelid to close well and is reducing the size of palpebral fissure that is coming to the required size. You add a 0.1 millimeter to that and use that as an implant. So this is a patient who has a larger palpebral fissure, who has an inability to close the eye or lag of thalamus. So we have done a tightening of the lid and combined for the lower lid, but for the upper lid to improve closure, we put in a gold weight here. Now you can see the closure is much better. Lower lid is not perfect. Even this closure is not perfect, but it is better than, much better than before. Cornea is no longer exposed and getting exposure keratopathy as it was getting here. So this is the procedure. Gold weight or even platinum weights are used for this purpose. So this is essentially what we commonly do for paralytic ectropion. Of course, there are a number of other procedures described. There is a neuronatization, which is done by plastic surgeons, where they try and put back the function to the seventh nerve by using some kind of a muscle graft, which brings in a nerve supply and increases the neuronatization. And there are other newer procedures as well, which are used. If there is a mass or growth in the lower lid, will be a classical example of a mechanical ectropion. So what you'll do is just treat the cause, whatever the tumor is, whatever the growth or whatever the edema is which is causing it, treat that cause. For a tumor, you may need to excise it and do a repair. If it is just a small one, you can excise it and reoppose the margin, and that will do the trick, combined with full thickness excision if associated with laxity and associated tightening of medial canthus or lateral canthus as required to correct the mechanical ectropion. So this is the essential principle in mechanical ectropion. So we've spoken about 4 types of ectropion and their remedies. Now, somebody to repeat what the 4 types are of acquired ectropion, and 1 line about congenital ectropion.
Dr. Raz Kania. Dr. Debashish. Dr. Debashish is there. Yeah, you are muted, Debashish. Can you unmute yourself?
Yes, sir.
Yeah.
Sir, congenital
types of ectropion.
Congenital and acquired. In acquired, it is a 4 type: involutional, cicatricial, paralytic, and mechanical.
Okay. Can you enumerate the procedures we do for paralytic ectropion? Just the common ones.
Sir, for paralytic, sir, we generally, sir, in case of temporalis fossa muscle transport, in case of generality done in case of leprosy patient.
Let's start with the simpler procedures before we go on to this. What are the commonly done procedures to take care of laxity and lengthening in cases or lateral canthal tendon, medial canthal tendon laxity in a paralytic lower lid problem. Lower lid is lax, hanging. What will you do?
Sir, in case of lower lid, we can go for full thickness. We can go for, sir.
Lower lid tightening.
Yes, sir. Lower lid tightening, sir.
How do you do it?
In case like lateral canthopexy.
Pexy will usually not work because this is a severe ectropion normally, severe laxity. So which one?
Severe cantholysis, lateral cantholysis, combined, sir. We can combine both.
So what is that procedure called where we do a lateral canthotomy?
Lateral canthotomy.
Lateral tarsal strip procedure or LT.
Lateral tarsal strip procedure, sir.
Yes. And on the medial side, if you were to do a shortening?
Sir.
What was the
Sir, in medial side, it is generally medial canthal plication combined with other procedure. Lazy T procedure.
Okay, lazy T can be done if you have to shorten it.
In
medial canthal tendon can be tightened. Okay.
Yes.
Okay, so medial canthal tightening, lateral canthal tightening, lid shortening. These are the common ones, but you can get additional support by using either a fascia lata sling in the lower lid, anchored at both the canthi and tightening the lid, or you can use a grip taken from temporalis muscle or temporalis fascia also. Okay?
Yes,
okay, and for the upper lid, if there is lag of thalmos, which is the most commonly used procedure now?
Sir, upper lid cases, sir, mostly we can use implant or explant like and lead retractor repair. Lead retractor repair is the surgery of choice nowadays.
Most often for lag of thalmos, what will work best is a gold weight or a
gold weight.
Gold weight. Gold weight, platinum weight.
If there is lid retraction, then
it depend upon the procedure, severity of the severity of the retraction.
Okay, but there are some temporary procedures also, which can be used as a temporizing thing. What are those procedures for upper lid retraction that you can use? Or you want to get a temporary relief in lag of thalmos?
Yes, sir.
So for temporary lag of thalmos, you can use Botox in the center of the eyelid from the conjunctival aspect, about 2.5 units to 5 units above the tarsal plate, and it will cause an immediate drooping within 3 to 5 days. And that can cause a temporary tarsorrhaphy lasting about 2 to 3 months, which can be a very useful technique to protect the eye. Second, in retraction, you can do a temporary thing. What can you do? Again, you can use fillers. Those are used for aesthetic purposes, but you can use these for several therapeutic purposes also. So for something like a lid retraction, you can also give a temporary, if you want to do a temporary thing lasting a few months, you can titrate and inject a bit of a heavyweight filler, which will cause a little drooping correction of the lid retraction. So those are temporary things you can do, but otherwise all the surgical procedures that we have spoken about. So I think that is about all from my side, Dr. Whom do I hand over to? Ajit.
Thank you so much, sir. It was such a wonderful learning and enriching experience.
Don't want to take up. That is
So, any questions from the discussants to Dr. A.K. Grover, sir?
Maybe ask.
And I would also like to invite
several alternate procedures that are used, and I'm sure many of our panelists are using the other procedures as well. So I would like to hear from them as to their choice of procedures. This is essentially very personalized presentation that I've done of the procedures that I find most useful and what I do most, rather than cataloging all the textbook procedure, because that may make things less easy to understand for the postgraduate and more to memorize. So my purpose was to give the most practical regime that I follow, and then they can read up some additional things once they've understood the principles. But I'm sure the other members of the panel use many other procedures as well. So I would like to hear from them.
Yes, for lagophthalmus, we can use suture tarsorrhaphy. That is also a temporary one and very easy. Like we can use either Prolene suture or silk suture. So that is just when you have a exposure keratopathy or a neurotropic keratopathy which has an exposure, then temporary we can do a paramedian tarsorrhaphy or a lateral tarsorrhaphy, even a median central tarsorrhaphy also for a certain period of time. It's very effective because we go along with the cornea specialist. So they also say that let's go for a tarsorrhaphy. If it's a temporary one, we can go for that. And
Thank
after a few weeks or months, we can just remove it and it comes to the normal. So after it is healed, so that is the best way. So
Correct.
that is one part. And of course, rest all is covered by you, sir. Completely very comprehensive, very exhaustive also. And the basics of the lid malpositions. So there are, of course, what I feel is it's all about practicing and titrating the ectropion, the degree of ectropion on table, because there is no thumb of rule that this much correction is required for this type of ectropion. So as per we do the cases, we experience it, how much to correct it, how much to tighten or keep it loose so that it exactly approaches to the globe. So we are wanting to have a maximal functionality along with the best cosmetic appearance which the patient wants, because these are all external procedures which you are doing. So we cannot hide anything from the patient. The day one they see everything in front of them. So we have to get the best of the results, whichever is possible way. So that is one thing I wanted to tell you. The rest all I think is covered by various methods are there, and whatever we are actually comfortable with or we get the best results, we can do that.
Thank
So
you.
I would like to add one procedure, if I mean it's possible. The time is it's actually running out.
No. We have time. Don't worry.
We are
So,
to hear from you.
We have time.
Yes.
but actually, I had one case where there was a traumatic medial ectropion because of malalignment of the canalicular tear. It had been repaired somewhere else, and when it came to me, so there was cicatrix in the canalicular area, and there was hardly any medial canthal tendon which I could feel. So what I tried to do is the upper canalicular was intact, and because there was a huge ectropion in the medial side and I was not getting any MCT, so I tried to use the tarsus on the medial side, and I took a Prolene suture and prayed to God that it does not hurt the lacrimal sac, because it's a completely almost a blind procedure to go hitch it on the posterior crest and then bring it. However, I fell short of the distance. So it was literally hanging behind. Somehow the ectropion was corrected a little bit, but not very satisfactorily. But this is something that I tried out for the first time and it somewhat worked. What are your thoughts on this? Would you ever try to do this kind of hang back technique of the tarsus, medial side?
Yeah. So essentially, this is what you need to do. In cases of laxity, etc., it works very well because you are able to pull it right there up to the posterior lacrimal crest. But it's not a blind procedure. Use a headband light. And if you have dissected enough and used a retractor in front and retractor behind, you can use those malleable retractors also, or use just Demar's retractor. You can see that area fairly well. If your direction after giving give a generous incision if needed in the precaruncular area, and go with your scissors directed back and medially, and you can very easily expose the medial the region of the posterior lacrimal crest, and you can work on that direct vision there by good
But the
retraction.
proline suture rubbing against the lacrimal sac and not
No,
the targeting.
so it has to be behind the sac, and you can get a good bite through periorbita and then anchor it to tarsus and pull it as much as you can.
Yeah.
It doesn't need really have to be pulled all the way.
Mm.
But the only problem is that sometimes the periorbita is not firm enough and it gives way. So
Yeah.
the other option then is the use of those mini plates. Just those mini plates which come for your in your set for fracture repair.
Mm.
Those two hold ones, what I do is I anchor it there with one of them with a short screw, about 4 mm screw, and the other one has a proline suture already passed through the other hole. And then use that suture to pass it through the medial part of the tarsus. This is what often needs to be done for correction of telecanthus. But that very direction of pull towards the posterior side of the medial tarsus works well to give you a good correction. But get a good exposure of the posterior lacrimal crest. There's no risk of damaging the sac if your direction is fine. In any case, you can use a slightly Steven scissors like thing which is not sharp so that you will not injure the sac. Just go in that direction till you feel the firm bone, and that is posterior lacrimal crest. Under direct, use a headlight and good assistance to retract it. You will see get a very good view of that area where you can easily put your microplate also, or use a proline suture to tie it.
Thank you, sir.
Thank you. So there are a lot of options. Dr. Aparna has given one good option for tightening of the medial canthal tendon, and Dr. Mihir pointed out some nice options for tarsi protection of cornea when there is a paralytic lag of thalamus. Any other, Dr. Sharmishta or anybody else?
Yes, sir. Good evening, sir. It's always so wonderful listening to you. And I think it's not without the reason that you are called Doyen of oculoplasty. So, you have very nicely covered, and you have mentioned all those practical tips also. There's one procedure which we sometimes do for paralytic leg of thalamus also, as well as for paralytic ectropion. That is, we use a silicone band or a celastic rod for what we use for dosage correction. So that we use as an encerclage procedure, passing through the near the lid margin of the upper lid as well as the lower lid, and anchoring it to the medial canthal tendon, as well as anchoring to the lateral orbital rim. So that provides some sort of encerclage, and which corrects the leg of thalamus as well as it corrects the ectropion part also. That is one procedure. And then in my practice, what I have noticed is that the lateral tarsal strip procedure is the main workhorse, and it's works well for the entropion as well as for the ectropion.
Absolutely.
So that is one. And
So
grafting
LTS procedure is a good procedure to do. Even when you are doing a Jones procedure, many cases are lax, and unless you do LTS, you will end up with an ectropion. So if you've done a good LTS, your ectropion will be taken care of. Similarly, in blepharoplasties, lower lid blepharoplasties, it is very important to do a lateral tightening as well, because most of the procedures done by other than oculoplastic surgeons often come up with general plastic surgeons and others. They often turn up with an ectropion because they don't have the same concept of tightening of the lid or things like that. So that is why they end up often with ectropion. And a simple procedure like lateral tightening often works in these to correct the ectropion. Unless, of course, they've excised too much skin, there's a shortening of skin also, then that needs to be replaced. Sometimes there is a middle lamina shortage that needs to be lysed. So all those things need to be done, which we need.
Even in case of skin grafting with cicatricial ectropion, we have to do a LTS also. because that also gives a very good tightening after putting a graft. Otherwise, there is contracture again sags down. So it's always good also if you see there is some chances of again the lid margin getting sagged down. So we can go for LTS.
One thing that I forgot to mention is that particularly when we do a grafting in the upper lid, it is always very useful to do a little tarsography as well for a few weeks, so that there's least movement of the lid and least possibility of contraction. If you don't do a tarsography and there's too much mobilization in the upper lid, you sometimes end up with too much contraction.
So you mentioned that we should wait for the scar to mature before we do any kind of procedure for cicatricial ectropion. So
Where
do
it
you
is possible to.
Yeah. So do you prefer to give anti-scarring injections like 5-FUs and all and wait to soften it?
Yeah, we often do that. So at a monthly interval, you can give 5-FU injections. They come in simple ampules and they are not expensive. So you can use to inject in the bed, and it often, sometimes it avoids that grafting at all. And at other times, it is able to reduce the amount of graft that is required by you by use of 5-FU. Sometimes in the earliest phase, sometimes combined with steroids also, either decadron or triamcinolone. These reduce the extent of scarring and they work quite well.
So you subject them to almost 3 times per month or maybe more also?
Once in a month.
Once in
a month. How long? And generally 3 or 4 injections is all that needed. It makes the scar supple, reduces the amount of scarring.
Okay, sir.
That can be done mostly in the initial phase when there is contraction is occurring, and even after post-operative period also, if you think that there will be a scarring and there will be again a contracture or recurrence, then we can go for injection of the FI.
This is a very useful tip that early post-op scarring also, if you feel the scarring is starting, use steroid or steroid 5-FU combination. It works well. I also sometimes, most of the times, for these cases, use a little bit of decadron, 0.5 cc decadron, also in my vial of 30 ml xylocaine, along with Hylase. Also make it 1 in 80,000 adrenaline to minimize bleed and to reduce post-op reaction. It works well.
Scar modulation is better than that.
Any other comments or questions? I think we've had some really useful tips from the panelists who added to the the procedures that we do.
Do we have an option for this scleral graft also? The spacer as a spacer. If nothing is like, if you don't have a gold implant, we can use that also. Yeah. So that also helps in
upper lid retraction.
Yes, for leg ophthalmos or retractions, that will also aid if you have a option for the sclera, donor sclera as a graft.
Absolutely.
And if sclera is not available, then even hard palate can also be used.
Yes, hard palate can.
Hard palate are particularly more often used for lower lid rather than upper lid.
Yeah, because it's
mucosa may not be very healthy for the cornea to the same extent as we would like it to be. But a tarsoconjunctival graft can also be used from the opposite upper lid. Sparing the marginal 4 mm, you can take a good strip from the opposite upper lid also. So I think then I'll thank Dr. Ajit Babu, Dr. Subuddhi, and the...
We should thank you. We should thank you.
Yeah, it's the reverse.
EIZOC team. No, it's a great thing to be able to...
Really good 2 hours actually. The last class also was a master class, and again today. It's now over to Subudhi.
Yeah, and I think it's a very, I would say it's very unusual today. and also last time also very extensive discussion about the entrepreneur Ectropion. Thanks, Dr. Grover. And I think everybody has learned, if not students, at least we learned. So
they also learned. They have done
no,
well.
they learned because they learned with the surgical
They
procedures.
done very well today.
So thank you very much, and we wish you please try to join with us anytime in future too. And also I thank my our panelists. Definitely they have contributed a lot of things to the text. And Pravisha, you have done a very good moderation today, and they initiated the program very nicely. And I thank all the post-year students here today, and they've enjoyed the talk. And I think they will be implementing the thing in practice. Thank you very much. Thank you all.
They
And last but
summarized
not
things
least is
beautifully.
our host today.
Postgraduates
Host
did
today
very
is
well.
the Entered Pharmaceuticals, who has provided the platform. Thanks to everybody. Thank you all. Good night.
Thank you.
Good night.
Thank you. Good night.
Bye-bye.
Good night.
Good night. Grover, thank you very much
Thank you.
for
Bye-bye.
accepting.
Bye. Bye.